Hi, Dr. Luckenbaugh.
Hi, Darryl. How are you? Good to see you again.
Good to see you. Can you tell us what kind of doctor you are and where you work?
Yeah, I am a urologic oncologist, so urology focused on cancers. I work at Vanderbilt right now as a faculty member here.
And Vanderbilt is in Tennessee, in
It is.
Nashville.
It is in Nashville, Tennessee.
So quite a lovely place to be, I would imagine.
It is. It is a little less lovely right now, like everywhere, but pretty lovely.
Cool. So today we're going to talk about screening and what that means. And we're going to focus mainly on the United States, but probably some of the ideas we talk about will be useful throughout the world, or at least throughout the developed world. So I mean, the word screening, I think of a screen on my window to keep mosquitoes out. Like, what are we talking about when we're talking screening?
Yeah, that's a great question. So, screening is the idea that we should try to diagnose a cancer or a problem early and find it before it becomes a problem. So that applies to other medical problems, but for prostate cancer, that means let's see if you have any signs that are consistent with prostate cancer, and if you do, can we find it early, prevent it from spreading, and reduce risk of dying from something like prostate cancer. So specifically for prostate cancer, that would mean screening is doing a digital rectal exam. So a finger in the rectum to feel the prostate. You can feel the prostate through the rectal wall. And when we do that, we feel for any lumps, bumps, tumors, any abnormalities in the prostate, and we know what that should feel like. And then the second thing in prostate cancer that would entail is checking a PSA test, which is a blood test that looks at a number which potentially could indicate that you have something suspicious for prostate cancer. It doesn't always mean that, but that is something that guides us to want to look further into things.
So that's all to say we actually don't have a test for prostate cancer.
That's correct. We don't have it. Neither of those things says, yes, you have prostate cancer. The PSA level can say, we think you might, and we think we should do a prostate biopsy to see if there is cancer there, but there is no blood test that says, yes, you have prostate cancer.
Yeah. I mean, here we are in, late 2020, early 2021. Why isn't that test around? Who's been sitting and not doing their job today?
Well, I think it's a little complex for prostate cancer and other cancers. We don't have great knowledge of whether the cells from the prostate can get into the blood, and we can find those with a blood test. And that's similar to something like breast cancer, colon cancer. There's a number, again, similar to PSA, that says maybe there's something going on, but it isn't very accurate unless we know you have prostate cancer through a biopsy and have removed the prostate. Then we can follow this number that we have, but we can't say just based on the number alone with no prior treatment that there is prostate cancer. And I don't think it's a matter of us not trying to find something. I think we all are, but it is a relatively reliable number that if it is high, we get a little worried and recommend doing further investigation.
Yeah, and everybody has a different way to interpret high, at least relative to PSA. The idea of this number of we'll get into in a minute, but let's just sort of stray a bit, look at some of the other possible tests just to get people thinking there may be something better in the near future. I mean, urine tests are being worked on, and there's some startups around, biotech startups, that are focused on just analyzing urine, sending molecules through different mazes to see which come out at the other end. What can you tell us about things like, and dogs sniffing urine as well? That used to be something we talked about a few years ago. What do you know about that kind of thing?
So yeah, there are a number of urine and now blood tests that use PSA in combination with a few additional aspects, and they can be slightly more accurate, but we would all say that we wouldn't base our decision making on that alone. Still, right now, it's not to say in the future that we couldn't develop things that do a better job. But there are blood tests and urine tests that can serve as biomarkers and improve the sensitivity of PSA testing. So if your PSA is 4, which is right on that cusp of is that normal or is it not, we might say you need a prostate biopsy, and patients might say, before you do that, are you sure? And in that case, doing a urine test or even a blood test with these additional added things that the tests look at, it can give you you are at a low risk for having prostate cancer and versus you are at a higher risk. And those with a higher risk, we would then say you really should have a biopsy. And those at a very low risk, we may say we can just watch your PSA level and avoid the biopsy for now and watch and see if this increases further.
Yeah, and the reason we would avoid a biopsy or even, discuss biopsy or not, what are the reasons for that?
I think there's two types of reasons. One group of reasons is avoiding having to go through the biopsy. It is a procedure where we put a probe in the rectum, and then we numb up the prostate most of the time while a patient is awake, and we take 12 biopsies of the prostate or more. And so it can be a little painful, but there is a real risk of getting an infection requiring hospitalization after the biopsy. It's under 5%, but that's still a risk. If we can avoid that, that is great. And then the second set of reasons to avoid a biopsy is there is all the controversy about our overdiagnosis of prostate cancer. So there is extremely low risk prostate cancer that some people say, why are we even calling this cancer nowadays? And those patients, when we diagnose them, we end up watching them most of the time. We don't treat them. And if we do that, it subjects them to biopsies kind of for the rest of their lives. So did we really need to know that they had prostate cancer if they weren't going to die from this? Probably not. So the reasons to avoid biopsy are the side effects, but also the fact that if it is a very low risk prostate cancer, people are more likely to die from something else than that low risk prostate cancer. They could have no problems with it for the remainder of their life. And we now have informed them they have prostate cancer, which can be a mental, but also a physical burden.
Yeah. And from our experience with massive numbers of people coming to our support groups for the last 20 years, the mental hit, the emotional hit, just the anxiety blow to them for Gleason 6 kind of guys for low is extraordinary. It's probably interesting to those in our audience who go to Malecare groups already know this. To people new to our organization, right now of our about 75,000 people that are in the online groups, and mostly because of COVID, because we shut down our in-person groups, 46,000 are just in the anxiety support community. We have separate community. Yeah. So the anxiety, and then the next largest number is the advanced stage group with around close to 12,000. But so imagine 46,000 people who identify anxiety, basically not being able to sleep, not being able to enjoy their day as the main problem they have with prostate cancer. Not impotence, not erectile dysfunction, impotence and erectile, not urinary incontinence, although those are large cohorts too, but anxiety. And it's extraordinary because it's all based, it all comes from the screening. So let's talk about screening as there are two, how do you screen for screening,
So how do you decide who should be screened?
Yeah.
Okay, yeah, absolutely.
I tried to make a pithy way to say it, but yeah.
Your way was prettier than mine.
Yeah.
Mine sounds too technical. So I think, a lot of this starts with the primary care physician, which is prior to urologists getting involved. But I think as the patients, it's important to know there are kind of a variety of guidelines out there, and it might be confusing because some guidelines say one age and some guidelines say a different age. And that can be a little confusing for us. It can be confusing for you. But in general, I can tell you the broad guidelines. For people under 40, we shouldn't be screening. That is not a group that we're typically screening or recommend screening in any organization. The urology organizations or the cancer center nationally, and that is not a group we screen. ages 40 to 54. So that's an age group that's kind of in the middle ground. And if someone has a family history of prostate cancer, that's really important. If someone is African American, that's also important. And if someone has a history of anything like breast cancer, colon cancer, pancreatic cancer, all of those things can be signs that there is a kind of mutation that could make them susceptible to developing prostate cancer later. And so between 40 and 54, those are people who, if they have any of those risk factors, they should talk to their primary care doctor about being screened, about having a PSA test to get to know what their baseline is.
Yeah, and it's the primary care doctor that's doing all this. It's not a urologist. People don't have to go to a specialist for this kind of thing.
Yeah, not at all. The primary care doctor should be able to do all of this. And now with more and more knowledge about risk factors for prostate cancer, and family history is one, and being African American is one, and having a family history of other cancers, primary care doctors should take that all into account. And as the patient, they can go to their doctor and say, look, my mom had breast cancer and my two brothers had prostate cancer. And between ages 40 and 54, it's reasonable to check one PSA level and see where that levels out.
Yeah, people sometimes use the word baseline.
Yeah.
I mean, is that really relevant, or can you talk a bit about that?
Yeah, you're absolutely right. Baseline is kind of what the normal PSA value for that patient is. And so in that 45 to 55 age group, if people have a PSA level less than 1, we know that they're at extremely low risk for developing prostate cancer later, because that's right around the average PSA level at that age. If their PSA level is more than 1, between 1 to 3, they're at a little bit higher risk. And so having that information when they're early in their 40s can help the primary care doctor to say, well, we will check their PSA level every 1 to 2 years. And if their PSA goes from 1 to 5, we know their baseline has shifted up and we might be worried and send them to a urologist. If a PSA value is more than 3 and you're 45, that's very suspicious, and that's someone who a primary care doctor should send to a urologist, even though they're young. Even if it just ends up being that we monitor their PSA, they are at a higher risk, and we know that now through a bunch of studies. But baseline is important because everyone is different, and I don't have a prostate, but say I did, if my baseline was 1.5 and it stayed 1.5 and never changed at all, nobody would worry. But if my baseline was 1.5 and 3 years from now it was 7, then we know that there's something going on and we should evaluate. And it may not be prostate cancer. It may just be that you have trouble peeing. It may just be your prostate has enlarged because you've aged, and maybe you have an infection, and that's why it's really an imperfect number.
Yeah, and we see guys that are, 15, 20 years ago called us up, and somebody answered the phone here and said they said my PSA, I'm a 55-year-old guy, my PSA is 3.5. What do I do? And we calm them down, and have like a discussion. And that person calls back again 2 years later, my PSA has gone up to 3.9. We calm them down, we have a conversation, and just to make this short, it's a made up guy, but it's actually a typical scenario where, now this guy, I guess he's 65 or 70 or so, and his PSA is 7. It's doubled in 15 years. We're still calming him down.
Right.
But his doctor is telling him, you got to have a biopsy. We're worried about you. How does that play out in real life?
Yeah, that's a great question. I think, PSA is it's good that we have it because it's really our only clue that something could be wrong, but sometimes it's bad that we have it because it can open a can of worms that may be entirely unnecessary and may subject people to a lot of anxiety. You're right. We still would probably calm that patient down, but I think the two things that I thought of while you were talking about that, one is if a PSA rises, we should always repeat that value and confirm that it's real, because there can be a single elevation that is meaningless. And so we would usually say in 2 to 4 weeks, let's check again before we jump on the biopsy bandwagon, especially if you're before it was normal and now it's 7. And sometimes a fair amount, the PSA value comes down, and we can't explain why, but then we say to that person, let's just watch. If it stayed up at 7, the reason we would say you should have a biopsy is mainly because we can tell 2 things from the biopsy. We can tell, is your prostate enlarged? Because we get a size. And then going forward, if it was enlarged and there was no cancer, we would say your prostate is just really big, and that is why your PSA is high now. But it also kind of helps us rule out, is there something that we have missed that we should be taking care of? And it's not those Gleason 6 cancers we want to find. We'd prefer not to find those. Unfortunately, we do find a lot of those. But we want to find those higher risk types of cancers that we can intervene on and hopefully prevent the advanced prostate cancer group from continuing to enlarge.
Yeah. And just before, so I don't forget, and so I don't have to keep writing notes to myself, would you ever do surgery on a 1 or 2 core 5% Gleason 6 guy?
No, I feel very strongly that I don't think that's the right thing to do. I've had people who really insist on it, and I try to either send them for a second opinion or counsel them more aggressively. I have not yet done surgery on a 1 core Gleason 6 person. I think that there are people who will do it, and I don't know that it's wrong, because that is what the patient may want. But I think that we are setting people up for a lifetime of side effects that maybe could have been avoided, or even altogether, or they could have been avoided for 5 to 10 years when the patient undergoes more biopsies and develops worse disease. I think it's not wrong to intervene, but I think that we know that that 1 core Gleason 6 is not going to be the cause of that patient's death at any time.
So let's return to the PSA thing. Worth talking about. It's not just one be-all, end-all test. There are different flavors, different assays, and patients are in a fog around that and don't even, are often not even told that, they should have a consistent assay. Can we talk about that a bit?
Yeah, absolutely. There's kind of 2 things. One, the PSA value, it can completely vary from lab to lab. It can be different if you have it done in New York or have it done in Nashville. It can be different if you have it done at Vanderbilt versus an outlying lab in Nashville. The outlying lab in Nashville could give you a value of 4, and you could come to Vanderbilt and you could have a value of 3.5. And now what do we do? You confirm it at the same lab, and you make sure that that number is consistent at the same lab. And then if you want additional information that isn't any of the new additional fancy biomarkers with the fancy urine tests, because oftentimes insurance won't pay for those, you can do a free and total PSA level. And the free and total PSA level usually is paid for by insurance companies. Most labs can do that very easily. It doesn't require any fancy gadgets or kits to do. And that free PSA level, if it is very low, that's something we worry about, that there may be a higher risk of prostate cancer. It gives you an additional data point. But I think it's important to know that this is before you have surgery or radiation and after. If you get a PSA value at one lab, it's not necessarily the same exact value at the other lab. And that difference can be anxiety inducing, but it's not usually medically significant.
So, and by lab, we're actually, is it fair to say we're actually talking about the brand of the test that's used at the lab? It's not the surrounding, they have a better waiting room, so I had a, better outcome on my PSA, or the coffee was better, or worse. It's like, what, I forget, do you know the names of who are the companies that make PSA tests?
I actually don't know the names,
Yeah, can't think.
but
Oh,
it,
Beckman or Beckman Coulter, and is one of them, I think. Well, whatever. There are at least two main brands, like Coke and Pepsi.
right.
And even though Coke and Pepsi, are pretty close in taste, there are some people that actually could figure it out. And I think the deal is Pepsi has a bit more sugar. So the idea that, you have, I mean, the ideal thing is you pick one brand. Hopefully that company will never go out of business, and you stick to that brand of test, and you could find out the brand name because it's written on the lab report.
The lab report, exactly, exactly.
Yeah. So good that you brought up FreePSA. Let's talk about that, because that's also, it sounds confounding, but it's actually can be anxiety reducing, especially in light of an elevated PSA.
Absolutely. I think, the free PSA level, for someone who has a PSA of 4, if we run that free PSA level, what we look for is to see, is there a large amount of free PSA or a small amount of free PSA, just to simplify. And if there is a high percent free PSA, that is very reassuring, and it can tell you that you have a very low risk of having prostate cancer. And so in men with PSAs in that kind of in between range, the 3 to 5, the 3 to 6, the 3 to 6.5, if their percent free PSA is high, then I oftentimes will watch those people's PSA rather than do a biopsy, because that can just mean that they just have an enlarged prostate, rather than prostate cancer, so to speak.
Yeah, and free means like the prostate specific antigen, the protein, is not attached to something. I forget what it's.
Exactly.
Yeah.
Yeah, that's,
So
yeah,
right. So the idea of, I mean, we use the phrase "more freedom is better," just so people sort of remember it. But
yeah,
it's usually, I mean, it's not like 100% free PSA measurement. It's like 20, 25%, and you're in a good
exactly.
place.
Yeah, if
Uh,
you're in
yeah.
single digits, it's a bad place, but um,
Yeah.
25 and greater, pretty good.
Yeah, the
Yeah.
good place and the bad place, and
Yeah,
it's a very good TV show.
it
So
is a good TV show.
yeah, so the idea of all these tests, it's really just a blood draw, and free
That's right.
PSA test is separate from the PSA test. You might have to tell the doctor, you know, check the box for the free PSA test as well as the PSA test, but it comes out of the same test tube.
Exactly.
Yeah,
Yeah.
more or less. Yeah.
Yeah, it
So
does.
yeah. So is there a difference in quality of screening from, let's say, rural to urban, or economically challenged neighborhood to super wealthy neighborhood?
Yeah. Um, yeah, unfortunately, if you had the test performed, there's no difference in the quality of the test performed. But the number of people who are getting screened in rural or economically challenged neighborhoods is lower than those who are getting screened in wealthier neighborhoods. That also, there's a racial discrepancy as well, and African Americans are usually diagnosed later and are screened later. Um, Again, I think that that's something that we all need to work on, and it kind of has to start with the primary care doctors. And unfortunately, um, the United States Preventative Task Force that didn't have a urologist on the panel about, gosh, 10 years, was it almost 10 years ago now, that said prostate cancer screening was recommended against, they kind of set us back um, a little bit with our progress. But we are now coming forward again now that they have said, oh, wait, backtrack. We kind of recommend prostate cancer screening. And so we really need to somehow reach those primary care doctors in communities. And that can be done in a variety of ways. I know churches do prostate cancer screening tests. There are vans for prostate cancer screening. And that simply would mean go in and get the rectal exam and get a blood draw. And they will give you those results. And it's pretty easy to do if you can find the place to do it. And most people should be now recognizing that you should have a PSA test done at least in your mid 50s.
Yeah, and the digital rectal exam. are doctors generally all competent at that, or is there really a disparity between, or discrepancy between some are really good at finding things and some just are doing it because it's part of the routine?
That's a really great question. I don't know that we have good like medical evidence, but I would say that it is really a subjective type of exam. It is you're putting your finger in a bottom and feeling for something that's supposed to feel like a walnut, and if you can't feel it, for example, some people have small fingers and might not be able to feel the whole prostate. Some people have primary care doctors may not have done a lot of them because it's not a part of their practice. And so they may not know what is abnormal and normal. But in general, most urologists can tell you you have a firm abnormality because we do a bunch of these a day. But it's like anything, the more you do, the better you are at it. Not everyone is going to be perfect at it.
Do MRIs play a part in the screening world?
Uh, that's a little bit controversial. I would say that they probably should not. We should have a baseline PSA before we use an MRI for any additional information. You should at least have done the very basics in terms of doing a rectal exam, checking a PSA. And if that PSA, again, is in that indeterminate range and we didn't get urinary biomarkers or blood biomarkers to help us, then you could do an MRI to see, is there a secret high risk lesion that is worrisome for prostate cancer? And if there is, that may guide you to do a biopsy, and you could do a focused biopsy. The issue with that is only focusing the biopsy on that one area. If we were to do that, it misses a number of clinically meaningful prostate cancers. And the other issue is that a lot of times insurance companies unfortunately won't cover the MRI unless you've had a prior negative biopsy. And that may shift, and it always depends on which insurance company, but that is something that is a little bit harder. So I don't think that just because an MRI is normal, if your PSA was 10, I would say, oh, you don't need a biopsy. I would probably still encourage you to have a biopsy because the MRI can miss 40% of meaningful cancers.
Yeah. And, I was just thinking about 15 years ago or 20 years ago, whenever I was first starting in the world here, I did a lecture in front of a community audience, mostly African-American men. And I learned a week later from the pastor of the congregation I was speaking in front of that almost every man in that, the pastor was very proud. Every man in that audience asked their doctor, not for a PSA test, but for a biopsy.
Oh.
And that just sent shudders up I knew I screwed up royally that day. It was like, if somebody's life was saved, great. But it was like, man, there's something about messaging around screening that in and of itself provokes a reaction that's could be toxic and destroy a person for the rest of their natural life. Where does, and it's been sort of trendy to talk about shared decision making.
Yeah.
And, really, I think that's more marketing. And, I have yet to meet a doctor who, I won't put you on the spot, but doctors that I've asked the question, have you changed anything, vis-a-vis shared decision making? And either they'll say, no, I've always been doing it, or I talk a little more with my patient, basically nothing,
Right.
Yeah. And it's just like, don't invite me to conferences about shared decision making.
Yeah.
There are better things to
Yeah.
do. But
Yeah.
around screening, we're actually, there's almost a command to, older men to go get screened.
Yeah.
Malacare's message is very simple. Any man over the age of 40 should have a discussion with their primary care provider.
Exactly.
But my counterparts are all saying a different message, more of the command method, and AUA and others, they don't say it that way, but it feels that way. What are the best what are better ways to sort of get across the idea? Screening is a good idea, but it's really not, if you can't handle it today, consider it next year or tomorrow.
Yeah, totally true. I think if you're at a point in your life where you simply don't have the bandwidth or the mental fortitude at that moment to get it done, for instance, right now, a lot of people are unemployed, are underemployed, have limited resources, limited time due to COVID. And if you can't get a PSA test this year, so what? Get one next year. And in most cases, almost, I would guess 80% of cases, that won't hurt you unless you're having some weird symptoms or something like trouble urinating, weird new back or bone pain. But really, if you can't do it this year, doing it next year isn't gonna really hurt you. It'll just be an additional information point for you and for your health going forward. I think that's the way to think of it. It's an additional information point. It's not much different than cholesterol. You check your cholesterol so that you know it's not high. If it's not high, you don't need any medication yet this year. And the PSA level, you check your PSA to make sure it's not high. If it's not high, then we'll leave you alone. But I think not having the information at all is kind of a disservice, and we should really at least talk to your primary care doctors about having it done. And I agree with the like 40s and up age group. It's something we should talk to the primary care doctor about as a patient. You may have to bring it up. You shouldn't have to, but you may have to. You may have to say, hey, should I have my PSA tested? And specifically, if you have a history or a family member or anything that you can say to the primary care doctor, hey, my brother was diagnosed at 48 and I'm worried. Can you check that? You should. And I think the other group, and I don't know if Malecare has a lot of older men, but in people who are over 75, at that point we say, does screening really benefit you? And it depends on, are you over 75 and still running marathons? If so, then screening probably benefits you because you probably will be living beyond 10 years. If not, then screening may just provide you with some anxiety point and result in getting biopsies, because we know that if you're unhealthy in 75, you're more likely to die from a heart attack, a stroke, another cause than prostate cancer. And so having that additional information may not really provide you with any benefit at all. It may just be something else to think about, something else to worry about.
Yeah. And, our keynote speaker, Pat Walsh, who's, basically
Pat Walsh.
Pat Walsh. And for those who don't know, Pat, he's basically the creator of modern day surgery, for prostate cancer. And but his idea, a very interesting idea around let's continue to focus on improving practice and surgery and radiation and everything and biochemical stuff. But if we could actually delay the onset of prostate cancer by 15 or 20 years, so that you don't have to even bother testing at a certain point. If everybody became vulnerable at age 70 or 80, then, or whatever, right. You're gonna, we think at Malecare, like if you die from prostate cancer at 120, we had a big success with you.
Totally.
We're happy for you to die from prostate cancer super late in your life and with a full life and a happy life. So this idea of testing, today, let's say in 2021, where, what do you do with an 80-year-old guy with a Gleason 7?
Right.
Yeah.
I don't, you have a shared decision-making discussion.
Yeah, right.
Yeah, and you say, I wish we never found this, to be very honest. Yeah.
Yeah, and frankly, all his friends will be saying that, but he may be under the knife,
Right.
or under the robot or whatever, under the puncture, and Warren Buffett is probably, great guy perhaps, but a bad example around this. An 80+ guy having, I think he had surgery. I actually don't know.
I don't know what he had, but I know he had it. Yeah.
Yeah, had something.
Yeah.
Yeah. Great to have the money to do that, but it's still like, I mean, his quality of life should be no more challenged than mine or anyone with less money than him.
Right.
I mean, nah. Anything else around this that you could think of that we didn't talk about?
No, I think this is great. I think we covered it all. I think it's important that patients need to realize that at times their primary doctor might not be thinking about this because they have a million other things about that person they're trying to think about. So keeping it on the radar, once you hit 40, keep it in the back of your mind, start talking about it with your primary doctor. And if they don't do it this year, they might do it next year.
Yeah. Thank you for taking care of your patients. Thank you for being part of our community, and welcome to the conference.
Thank you. Thanks so much for including me. It was really great.